Managing non-pain symptoms in palliative care. Did you know? Most patients experience more than one symptom at a time. In advanced cancer, 35% to 96% of patients experience pain, 32% to 90% experience fatigue, and 10% to 70% experience breathlessness. In palliative care, these non-pain symptoms can impact quality of life just as much as pain. Today, we'll cover 4 key areas: nausea and vomiting, fatigue, anorexia, cachexia syndrome, and artificial nutrition and hydration. Nausea and vomiting can result from metabolic change such as hypercalcemia, increased intracranial pressure, GI issues such as bowel obstruction or peptic ulcer disease, or medications like opioids and chemotherapy. We need to identify the cause before treating. NCCN recommends: 1. Identify and treat the cause. 2. Use scheduled antiemetics. 3. For breakthrough symptoms, rotate drug classes. Dopamine antagonists, haloperidol, metoclopramide. Atypical antipsychotics, olanzapine. 5. HT3 antagonists, ondansetron. Cannabinoids, dronabinol. Corticosteroids, dexamethasone. Benzodiazepines, lorazepam. Nausea and vomiting remain some of the most distressing symptoms for patients undergoing cancer treatment. That's why evidence-based guidelines are essential. The NCCN guidelines for antiemesis provide a standardized approach for preventing and treating nausea and vomiting associated with chemotherapy, radiation, and surgery. According to the NCCN, National Comprehensive Cancer Network, prevention is key. Prophylactic antiemetics should be administered based on the emetogenic risk of the chemotherapy regimen: high, moderate, low, or minimal. For highly emetogenic chemotherapy, like cisplatin, a 3-drug regimen is recommended: an NK1 receptor antagonist, a 5-HT3 receptor antagonist, and dexamethasone, plus or minus lorazepam, depending on patient profile. For moderate risk, a 2-drug combination is usually sufficient: 5-HT3 antagonist plus dexamethasone, plus or minus lorazepam. For low risk, metoclopramide plus or minus dexamethasone or diphenhydramine or prochlorperazone plus or minus lorazepam. For minimal risk, no prophylaxis, as needed antiemetics only. Breakthrough and anticipatory nausea should also be proactively addressed, often requiring rescue medications and non-pharmacologic support. The NCCN guidelines for breakthrough treatment for anti-cancer therapy induced nausea, vomiting. Tailoring antiemetic therapy means considering the regimen, patient risk factors, and prior experience with nausea. Following the NCCN guidelines improves symptom control, treatment adherence, and quality of life. Fatigue is complex. Reversible causes like anemia or sleep disorders should be addressed first before going through the route of medications. Use non-drug methods like energy conservation, and consider methylphenidate, 2.5 milligrams twice a day in frail elderly. Modafinil, 100 to 200 milligrams in the morning. Short-term dexamethasone for patients with limited prognosis. Appetite and weight loss are common in advanced illness, part of a syndrome called anorexia-cachexia. Treatment options. For those with weight loss and depression, anorexia, consider mirtazapine, 7.5 to 30 milligrams per oral QHS. However, need to monitor serum sodium as can cause hyponatremia. Those with ACS and gastroparesis, consider metoclopramide. ACS and malignancy. Magesterol, 200 to 600 milligrams per oral daily, but remember it can cause weight gain, which is primarily water and fat, 15%. Adverse effect include adrenal insufficiency, thromboembolism, hypogonadism. Not recommended by AGS, American Geriatric Society, Beers criteria. Olanzapine 5 milligrams once a day. However, there is insufficient evidence to support its use. Dexamethasone. The effects can last 4 to 8 weeks. Average dose is 2 to 8 milligrams per day in those with prognosis of weeks. Cannabinoids? An example is dronabinol, 2.5 milligrams twice a day, approved for anorexia secondary to AIDS and for refractory chemotherapy-induced nausea and vomiting. These may help, but each has risks. For example, megestrol can cause thromboembolism and adrenal suppression. Always tailor treatment to goals of care. Artificial nutrition and hydration, like feeding tubes or IV fluids, are often requested at the end of life, but they aren't always beneficial. In some cases, like ALS or head and neck cancers, ANH can support quality of life, but in advanced dementia or terminal stages, it may cause discomfort, fluid overload, or aspiration. Consider patient goals. Focus on comfort. Communicate clearly with families. Shared decision-making and honest conversations are key. ASCO, American Society of Clinical Oncology, guidelines therefore recommend that patients with advanced cancer should receive dedicated palliative care services early in the disease course and concurrent with active treatment.